Hi, I'm now going to go over the standard flow of use for the Mini-CEX assessment tool. There's some simple ways to remember what the requirements of the use of the Mini-CEX assessment tool really is. One, actually, let me go through all of the things that I usually remember when it comes to Mini-CEX is first is preparation. Preparation is going to be mostly the intern responsibility, but as instructors of record and clinician instructors for these courses, you really have to keep track of if your interns are accomplishing the assessments also, and reminding them that this needs to be done. However, it will be the intern's responsibility to actually accomplish these too. Observation, evaluating the student skill set, and also the competency of the student. Documentation, um, making sure that we're putting in the scores, especially for the different competencies and the requirements of the competency. And then lastly, consultation. Again, this is not going to happen each and every time that we have an assessment, but if there is a major deficiency or for the purpose of early assessment, will need to have a consultation with the student. And so preparation, again, daily schedule, the clinician and the intern will see the schedule and make sure that we are looking to see what needs to be completed regarding their mini CACs and what is reflected on the patient care schedule that day. And so again, you should be reminding the students of this, but really it's the intern responsibility to see what categories and procedures are needed, which categories and procedures the intern is ready and proficient in. The intern should be practicing, should be studying these tasks, these attributes, and these skills um, of clinical competency. And also, does the intern need to show improvement? Do we need to also take a little break from assessment because maybe we have a lower score and the intern needs a little bit more time? Those are questions that you and the intern need to answer yourselves. Again, the intern has most of the responsibility in preparation, obviously. Does the intern have doubt of their own competency? The intern should practice. Does the intern know the clinician's expectation? This is where the intern should ask, a conversation should happen, and then study and practice, uh, hopefully with other interns also that may need, or maybe senior interns also. So speaking of that, the intern should utilize peer feedback before really an official mini CACS evaluation to get ready for that assessment. That's one of the most powerful ways that an intern can really get ready for an assessment is to practice with another intern and then get that peer feedback, especially if it's more of a senior intern. And then the intern clinical day should be just filled with either patient care or studying, practicing, and learning from other aspects of patient care. Hopefully, practicing with other interns. But really, my point here is that there really should be no downtime. If there's no patient care, then the intern really needs to be studying and preparing for his or her next assessment. Another point that I have to make, and again, we're getting into observations here, is that when the clinician evaluator is doing these mini CACS assessment, really we need to do more than one assessment category at a time. And so previously I trained upon that these assessments only need to be 3 to 5 minutes, but we should also be aiming to do 3 to 5 categories per assessment too, because a lot of these are related to each other. They complement each other. We'll get into that, and we can really give feedback to multiple categories versus just focusing on one category like medical interviewing or physical examination. We can see how it ties into professional and ethics, counseling skills, etc. Any patient encounter can be used for Mini-CEX assessment. It doesn't have to be a new patient, doesn't have to be a reactivation or a reevaluation patient. It can be any patient encounter, a follow-up that can be used for a Mini-CEX assessment. And the clinician does not, like I said before, does not need to be present for the entire patient encounter. That I think would be counterintuitive for patient care and doing the seamless intern assessment. Just enough have a good picture, formulate a score, hopefully have some brief, meaningful feedback, giving some references. And again, what we're aiming for is 3 to 5 minutes. Be present, observe, and then excuse yourself out of the room, and hopefully going to a second uh, assessment there. So an example here, and really this is like bare bones examples of assessments that we can do. We'll get into which 3 to 5 categories we can do also in the next slide. But for the observation, if we're doing a history, really bare bones is, for example, medical interviewing category, we're going to assess in that category and rubric, but we're also going to assess in the clinical judgment category and rubric. For an exam, we may be able to do more physical examination, organization and efficiency, counseling skills, and then treatment, therapeutic skills, but we could also do organization and efficiency. If the patient, I'm sorry, if the intern is speaking, also, we could also do counseling skills. We could do clinical judgment if we're maybe speaking to the intern afterwards. What are some critical thinking skills that the intern has from either the therapeutic skills, the outcome of that, and then maybe to the next visit. And so speaking of that, we have to think about combinations of observation when we're actually doing these assessments too. Documentation. Um, each of these categories are going to have a requirement or has a requirement for the number of assessments specific to the trimester. And so the student will need a certain number of assessments per category, but also per subcategory also. Before I get into that, I just want to reiterate about doing multiple categories and subcategories per evaluation. So we could do medical interviewing. We could also do obviously counseling skills, organization and efficiency, possibly clinical judgment. And so we're really focusing on doing multiple assessments per patient encounter that we observe. Another example would be uh, physical examination. We can also do counseling skills, organization and efficiency, um, and then I don't have it up here, but also professionalism and ethics. So I'm missing one. I apologize. We're missing one category here, professionalism and ethics. I will go through it when I go through all of the rubrics and descriptions of the categories, but I am missing professional and ethics on this list. I apologize. But all the Mini-CEX rubrics and category descriptions have been mapped to the CCE metacompetency descriptions and the outcomes. And so all of the outcomes are included in the Mini-CEX rubrics and the descriptions. The Mini-CEX is just one of the tools that National uses to evidence competency. We have other tools and different layers to evidence that they've actually been doing these metacompetency outcomes. And so at the end of their preclinical and their clinical courses, all of the students have evidence competency through these clinical outcomes. If a student is clinically competent, then Mini-CEX assessments must be documented for the specific trimester. Remember that we have specific requirements depending on the trimester, try 8, try 9, try 10, or the student cannot progress to the next trimester. And so if the student is not making those assessments, both by the number of assessments, but also by the standard threshold or quality of the score in these assessments, the student cannot progress to the next trimester. And so these standards, these thresholds will be given to you. but these have to be made. I'm going to go over the nature of the rubrics and the nature of scoring also, so that will help you. And also the opposite is true. If the student is not clinically competent, we must document this also. And hopefully the formative assessment is helping with this, with identifying some weaknesses with the interns. Hopefully it's not a common occurrence. Hopefully it's a very rare occurrence. But if we do have an intern that is just not improving, that's not clinically competent, that intern may have to repeat that trimester and hopefully improve in those competencies and those skills in that same trimester. So consultation, this is probably the smallest part of Mini-CEX, but it's still very, very important. It may be needed to have a one-on-one or even a group consultation with your students to see what needs to be improved, which categories and procedures are still deficient. And so when we do that, there could be just, let's say, medical interviewing, just maybe the whole trimester or a number of students are just not getting the essence of doing a medical interview or certain parts of the medical interview. Do a consultation with the intern or the group of interns, document that, and that's going to be a very effective procedure or action to do, tasked with these interns. But also early assessments, especially when we're getting into, week 3, the Mini-CEX evaluation assessments can serve as that early assessment for the clinical practice department, and any consultation that is done with these interns for lower than expected performance should also be documented in the advising notes too. So hopefully that helps you a little bit more with kind of the flow of Mini-CEX and how we will prepare for these assessments, how we observe, how we're using 3 to 5 minutes, 3 to 5 categories and subcategories each time, how we may do documentation, making sure that we're getting each category for the requirements of the student, but also if there's any needed needed consultation for the students, that we're doing that also. Other training that you may see too, obviously background and overview, uh, the nature of the Mini-CEX rubrics, things to remember with that, explanation of each rubric and category, we'll get to that, including professionalism and ethics, which I forgot to put on that list, and then also entering the Mini-CEX scores into Office 365. If you have any questions, please reach out to me. Don't hesitate to do that. Very free to make individual trainings per clinician or videos for the whole group. Here's my contact information and my phone number. Thank you very much.